So Renu, we're back at ORSI, the ORSI Academy in Belgium.
Yes, we are. This time for a very important discussion meeting.
Yeah, so one of the hottest themes in prostate cancer this year has been intra-operative margin assessment. That's how do we do better quality nerve sparing during radical prostatectomy, but without sacrificing margins. And it's been a hot topic for us on GUcast this year.
It has. We've had a couple of podcasts on it. It all started off with the Neurosafe trial being read out at the game-changing plenary at EAU, along with the publication and our podcast, of course. And then when Greg Shaw visited us in Melbourne earlier this year, we did another podcast on, this time, the Histolog, or the Confocal microscopy. So this is what this meeting is all about.
Yeah, so we're here in Belgium for a very special 2 days here at the ORSI Academy. Today, day one, there's a Delphi consensus meeting to discuss intra-operative margin assessment. And I think it's a particular focus on confocal microscopy. Confocal microscopy. There are a few technologies out there using confocal microscopy to try and improve the way we can assess margins during surgery. So the idea being we do nerve sparing during surgery, but while we're still in there, we pop out the prostate and we do an analysis there and then to see, do the margins look clear? So that's in summary what intraoperative margin assessment is. So
essentially trying to make Neurosafe a little more feasible in day-to-day clinical practice.
Because for those of you who don't know anything about that, Neurosafe is this process of doing positive surgical margin assessment using frozen sections, which has now been really established as level 1 evidence thanks to the Neurosafe trial, Lancet Oncology, saying, yes, if you do that sort of assessment, you're going to improve the quality of your nerve sparing, and that leads to better quality sexual function for men. So obviously a big hot topic.
Absolutely. And we've started using Histolog a little bit in Melbourne, but you know, it's a new technology, so we do need to have some important decisions made, or at least a consensus reached in where the real applications for this are.
So that's day one today. Literally in a few minutes here at ORSI Academy behind us, there's a Delphi consensus statement with all sorts of experts in this field of intraoperative margin assessment. We'll be tracking down a few of them to have a chat about it. And it will lead to some significant publications. The editor-in-chief of the BJUI is here, Freddie Hamdy.
Freddie Hamdy.
Yeah, and there's going to be a themed episode, or a themed what do you call it if it's not a podcast? Edition of a journal. A themed edition focusing on this area of intraoperative margin assessment. So we might track down Freddie for a chat. Ruben de Groot, who was on our previous podcast, is putting this together. Greg Shaw is here. So we'll track down a few of these experts, and maybe one of the pathologists. We have pathologists here as well.
Absolutely, yeah.
But that's just day one. That's a long meeting that's going to run till 7 or 8 o'clock this evening.
Yeah.
And then tomorrow?
Tomorrow is the WRSE 12 program, 12 hours of live surgery with a special focus on intraoperative margin assessment.
That's right. So there's going to be piles of these live surgeries happening from the WRSE, and again, we've posted about that on our channels before, hosted by Surgquest, Ruben de Groot and co, who are the digital extension of ORSI as they describe themselves. But yeah, we're going to see a lot of live intraoperative margin assessment using technologies like Histolog, which is the one we've been experienced with in Melbourne. So yeah, it's an exciting couple of days.
Yeah, and we're going to bring you all the highlights of the next couple of days.
Sure.
But before we get into it, what is confocal laser microscopy and what is the Histolog scanner? The Histolog scanner is a specialized confocal laser microscope used for the rapid real-time imaging of fresh human tissue surfaces during surgery. It is primarily designed to help surgeons and pathologists perform intraoperative margin assessment. That is, checking that no cancerous cells remain at the margin of the specimen, without the need for time-consuming traditional processes like frozen section. The workflow is extremely favorable, as the specimen can be prepared and scanned within 5 minutes of removal from the body. Here you can see me retrieving a prostate immediately during robotic prostatectomy and taking it to the Histolog scanner in the corner of the room. The freshly removed specimen is dipped in a special fluorescent dye, the so-called Histolog dip, for 10 seconds and then washed in saline and dried before being positioned on the confocal laser microscope. The images produced look very similar to microscopic histologic images, providing 2-micron resolution. And the specimen, of course, still undergoes traditional formal pathology assessment following the surgery for verification. Surgeons or pathologists in the operating room can instantly access the images, or a pathologist can also access the Histolog console remotely to provide expert opinion. Data recently published shows that Histolog is very reliable for assessing prostate surgical margins of 3 millimeters or above, which is usually what we consider to be clinically significant. This means we can offer much more aggressive nerve sparing while still ensuring good cancer results. During this recent Delphi consensus event at the ORSI Academy, a group of the world's leading experts in intra-operative margin assessment for prostate cancer, including teams with extensive experience with traditional technologies like Neurosafe frozen section, as well as teams with clinical trial experience using Histolog, gathered together to discuss this hot topic. The meeting was chaired by Dr. Ruben de Groot, with a multidisciplinary panel from all around the world, including urologists and pathologists. It was a tough meeting. There was very robust discussion on how we should incorporate intraoperative margin assessment and new technologies like Histolog into prospective studies and prostate cancer surgery workflow.
So, Renew, we have tracked down Ruben de Groot again, having seen him on an episode just recently.
That's right, Ruben. You have put in a massive amount of work getting this day together. This is a day of the Delphi consensus for intraoperative margin assessment. Huge day for you. You had a team helping you, but this is a huge bit of work.
It has been a huge bit of work to get all these people together from around the globe. It's a massive effort from the whole ORSI team here, so thanks to them. So we are about 1/3 through the Delphi now. It's not easy to get everyone on the same page on different topics. You know, we have minor details, you have major details to be discussed, so let's hope that we can have a nice consensus by the end of the day. But I think the prize is in the effort, and by the end of the day we hope to get a prize.
And I suppose we're all teasing this out, Renew. It's been a really popular topic, as we said earlier, on the podcast, because it's an important topic. But I think to have this type of group in the room where you've got, very senior prostate cancer surgeons and very senior academics, editors-in-chief, pathologists. I'm stunned at the number of pathologists physically here and online. So engaging with our pathologists in this discussion surely must be very important.
I mean, the fact that pathologists are here on site and also online with us is extremely important, because confocal microscopy is, of course, not something only to be addressed alone by the surgeons, but it's really something which goes hand in hand between surgeons and pathologists. So having them here and valuing their input is extremely important for us. So we'll come back later in the Delphi today to the more specific details on pathological examination, who needs to do the evaluation on confocal microscopy. Is it the surgeon? Is it a pathologist? How do you need to do it? It's all questions that needs to be answered throughout the day.
Okay, well, good luck to you. It's a quick coffee break time now, so we better let him go so he can recharge and try and manage this mob for the second half.
Absolutely.
Thanks,
Ruben.
Thank you. So, Renew, another coffee break at the Delphi consensus
meeting.
meeting.
The meeting continues. Lots of difficult questions being thrown out there.
Yeah, so we've interrupted the coffee break of Matt Winkler, urologist and old contemporary of mine from London at Imperial, and Anna Silvanto, GU specialist pathologist at Imperial. Thanks very much for joining us.
Thanks very much.
Thanks for having us.
So, Matt, first, you've been running a study, you and Anna and co, the FLOREST study, the IP8 study, I think it's also called, which will be coming soon in a big journal, which is your experience of using Histolog, one of these confocal microscopy technologies for intraoperative margin assessment. And regular viewers and listeners will know we've already done a whole episode on the Histolog and, of course, a whole episode on Neurosafe. So just from a surgeon's point of view, can I ask you, what's your experience of embracing Histolog confocal microscopy in your practice? You don't need to tell us the study results. I know it's coming very soon, but your experience of using this practically.
So yes, correct. This is exciting technology, and we all want to do a better job, preserve more nerves, and respect the oncological outcomes. So for now, the techniques used is the Neurosafe, and that is very expensive, and we have a huge gap in the provision of pathology services in the UK and also in other countries. So what we need is something to do the same at less cost and hopefully as accurate and shorter, so that we have that intraoperative information to act on. And what we have done is, because there was nothing to guide us how to use the new scanner, what we have done is look at the whole prostate as it is removed. So this is an accuracy study without acting on the result. And we wanted to make that prospective, blinded, and we have built in a prevalence adjustment every 50 patients recruited. So we recruited close to 200 patients. And so this is a statistically very robust study, which tells us three things. How good is it?
Compared to final pathology?
Correct, yeah, compared to final pathology. How good is it? How many cancers does it miss? And what is the limitation of detection of cancers, i.e. how many millimeters can it see or not? And is there a problem with using it in different locations of the prostate? So we stent the whole prostate, because obviously, as you may remember from the Neurosafe podcast, only the posterior and posterolateral surfaces are usually assessed. So you wouldn't have any information about the rest of the prostate, and if there is a prostate margin there. So that's the basic premise that we started with.
So that'll be very informative, Renew, I think,
Absolutely.
won't it, when we see that coming in a popular magazine very soon, hopefully as well.
Yeah, I mean, it's an interesting time, Anna, that we're in, because pathologists have had to get involved in a part of a prostatectomy and, that they've never had to before, and guide decision-making in the middle of a case. Where do you see the future of confocal microscopy? I mean, it seems like a much better alternative to Neurosafe, much more feasible from a
perspective, at least.
Absolutely. Yeah. But what's your opinion? Where do you think it will fit in? Where will we be in 5 years?
Yes, I think the confocal microscopy is actually a really exciting prospect. I think it's going to offer the chance of for a lot more men to undergo nerve-sparing surgery.
Yeah.
I also do some neurosafes, and I'm very aware of the time it takes to get the result, up to an hour. So I can really understand that it's really not feasible in most centres and most countries even. So I think this has shown itself to be a really quick, sort of rapid, accurate assessment of margins. And what we have found is there's variation in the quality of the images produced from various margins of prostate. For example, the posterolateral margin, which is the really key area for preserving neurovascular bundles, is actually we get really nice images, and actually the sensitivity is quite good for clinically significant margins, whereas other margins, base, apex, for example, are not that great.
Yeah.
But I think it's got a lot of promise for the future, for a lot of men to benefit from reduced side effects of surgery. So I think it will be...
It does feel like we're at the start of a wave of it, with the interest driven by Neurosafe to say, okay, Neurosafe has shown it does achieve its goal of increasing the proportion of men getting nerve sparing, and that translates into better outcomes. So we were chatting to our pathologist in Melbourne about this, Anna, when we started using Histolog, and Andrew Ryan, a very trusted pathologist that we work with, came into the operating room to watch us doing it, and we said, well, what do you think? And he said, well, look, he said it's different to what I do. This en-face examination of the prostate, but the prostate going onto the objective and we look at it is very different to normal sectioning and calling margins. So he kind of said, well, you guys and girls should get good at it. Fine, I can learn it. I'm used to looking at images and so on, but you're in the operating room. You're used to looking en-face at the prostate as we dissect off the neurovascular bundle, and it's one of the questions obviously we're talking about at the consensus meeting is what is the role, do you think, of the surgeons in the operating room using this type of technology in cooperation and pathologists and so on? But what do you think about that? Because it's a different mindset, isn't it? The en-face interpretation instead of...
So obviously it's a different way for us pathologists to look at the margin, because we look at the transverse sections normally, and this is an en-face, so it's new for us too. And I think there's no reason why a surgeon couldn't learn to interpret images as well, and interpret them directly in the OR and correlate margin positivity where exactly they see in the surgical bed, for example. I'm not a surgeon, but I think it'd be quite nice I would imagine it'd be nice for a surgeon to know exactly in OR themselves what area is positive and what's fine.
Sounds hard, Matt. Is that something you'd like to do?
Absolutely. I mean, I think this is what created the interest in the first place, that you get these fantastic real-time images, and they are actually quite easy to interpret after a little bit of training. So a junior surgeon had done the scanning, and myself, we looked at it and we could pick out cancer quite quickly. which is the first time that we were sort of having that ownership, of the process. And of course, if that is aided, and we have discussed sort of the place of machine learning interpretation in this meeting here, if there is a little bit of guidance, i.e. there's a region of interest highlighted by an AI agent, then of course it would make it much easier for the surgeon to pick out what cancer is or not and how long it is, in diameter, or what the surface area is. So this is fantastic. We embrace it.
I think so. It's awesome. So
It
we're going
is
to look
exciting.
forward to that study coming, the Flores study
absolutely.
From Imperial. And, I think we'll be featuring that on the podcast again when it comes out. So congratulations to you all at
Well done.
Imperial,
Great effort.
Matt and Anna, and Nick Mayer, your research fellow. And Nick, actually, I hadn't seen him for years, but he came down to Melbourne, I don't know, it must be 8 or 10 years ago when he was a medical student. Procar Discup to send him down. And he was a really bright spark and wrote a few papers. And here he is now, and he's... So.
He is the motor
The
of
driving
it,
force.
yes.
Okay.
Very promising, and he's the main man in the Transform study as well, so we will hear a lot more from him. He has already planned 5 or 6 follow-on studies on the data set, so yeah.
Wonderful.
That space.
Watch that space. Thanks so much.
Okay, we better let you get back to the meeting.
Yeah. So we're still here at the intraoperative margin assessment meeting, and we've tracked down Professor Freddie Hamdy, editor-in-chief of the BJUI, among your many hats, and you've been a participant in the Delphi consensus meeting, which was yesterday, and here at the intraoperative margin assessment live surgery WRSE event.
It's a marathon.
It's a marathon. Are
Been
you
there
enjoying
for
it?
It is a
almost half
marathon.
of
Very
it.
much enjoyed it, and I think the Delphi wasn't as simple as we thought it would be, and it raised a number of very interesting issues, and it does make a difference when you sit down and you think about them systematically. So no, it was great. Really enjoyed it.
We want to pick your brains a little bit as an editor-in-chief of the BJUI, and we figure we're all as clinicians kind of at the start of this intraoperative margin assessment experience. But for you, not just as a prostate cancer clinician, but as an editor-in-chief, what do you think are the key questions, the important academic and clinical questions we should be setting
What are
out
the trials
now?
you'd like to see
we're
in
only
this
at the start
space?
of this.
Yes,
What do you want to
that's
see
right.
coming across your desk, both as a clinician investigator, but especially as an editor-in-chief? Because we need to be planning these trials.
So yeah, the 2 hats which will allow me to answer your question is, one is my academic curiosity hat and evidence generating, and the other one is that the dream of any editor-in-chief is to get on his or her desk the best possible manuscripts with the best possible studies to change the world. So what messages have I got? I think I learned an awful lot in the last 2 days. If I just focus on this very intense desire to identify positive surgical margins, not just for prostate, but we've seen kidneys, we've seen adrenals. I would like to just have maybe a couple of thought-provoking ideas. The first one is that we should try and uncouple the spinal reflex that many surgeons have, that we must not have a positive margin. Positive margin is a complex issue which is really important only in the context of the biology of the disease, which causes the positive margin itself. So in other words, does it matter if you have 1 millimeter, if you have 2 millimeter? Does it matter if in prostate it's Gleason pattern 3? Does it matter if it's Gleason pattern 4? And if you do find it, what do you do after you find it? And I think these things are really important, because we do have fantastic new tools, possibly to be able to identify positive margins, but then we need to think, what do we do afterwards? My biggest issue, if I'm really honest, is that the pathologist who tells us, whatever way you use, whether it's confocal, whether it's Neurosafe, they will tell you what you have so skillfully taken out. They will not tell you what you're leaving behind. Yeah. And what are we really interested as surgeons to make a difference in cancer biology is what we leave behind. Now, there are other groups, including ourselves, who are looking at what you leave behind, and that's by imaging cancer cells using different techniques, radioligands, using fluorescence with molecular targeting, etc. And I really think that the future needs to be combining these very refined techniques of finding your positive surgical margin, but also looking for residual disease and removing it where it matters biologically. Does that make sense?
It does. It means it's going to be complicated trying to plan correct trials, isn't it? Because some of these variables you can measure, for example, simply is the intraoperative margin assessment using confocal microscopy going to correlate with, as you said, the expert opinion you'll get a week later.
Absolutely.
But that's only one simple thing. There's so many other convoluted things, like trying to identify, I think what you just said was the nature of what, if any, tissues left behind. And even then, the impact down the line of things like biochemical recurrence or metastases and so on. So everything's a little step in a process that may or may not actually help the patient.
Totally. And I think we need to embrace the technology, but we need to embrace it intelligently, and we need to use metrics to be able to validate them, to understand what the real meaning is. So for margins, is what you see is what you get? Is what's on the label what's inside the tin? And then do the proper validation studies. You're never going to do studies to look for outcomes like mortality or development of metastasis. We're dealing here with relatively early stage disease. So you've got to have surrogates which actually allow you to say this course of action is the action that needs to be taken. And we've seen some examples where you ask the surgeons very elegantly doing a difficult case and say, oh, we had one with 2 millimeter margin. And you ask the question, so what do you do now? And we had 3 different answers.
Yeah.
Yeah.
And the problem is, that's one decision to be made. If you have a positive margin, what, if anything, do you do? And then if you go back and re-resect, have you really done the patient any favours at all?
Or worse,
Even if that were positive in your re-resection, or if it was negative, you still don't know if you've done any help.
We touched yesterday on full resection of the neurovascular bundle or partial resection, and I've never seen so many divided opinions about partial. Nobody could describe what partial resection of the neurovascular bundle is. And even if you do, how do you know that there's nothing left behind?
And the very interesting thing was we had pathologists in the room for the consensus meeting, and even though they kept telling us that there is no point re-scanning partial resections, people still choose to do it.
That's right. Yeah.
Do you think, Freddie, because this is all about a balance between trying to preserve or restore quality of life for prostate cancer, at least by trying to improve the nerve sparing. And I mean, we all, from Neurosafe, it's very impressive, isn't it? More and better nerve sparing equals better outcomes for patients with sexual function. Sure. So do you think, how do we involve the patients in this discussion? Because I think a lot of it comes down to, what are the things that really matter to you? What would you accept if we have a...
It was a very pertinent question yesterday that we discussed, is how do you counsel the patient when you do these techniques? One comment that was made me a little bit uncomfortable, and that was about marketing a technique for the patient. And, that obviously is not something that, we should be very, very careful about. Counseling the patient, how does it matter to the patient? We're going to find a positive margin. And the other thing we need to be careful about is raising the anxiety levels of the patients unnecessarily. So are we telling the patient your margin is going to matter or it is not going to matter? And if it isn't going to matter and you're going to leave it behind, why actually find out at the time?
Yes.
So it's a balance about, we're dealing with a patient there, and they will not understand the subtleties of whether a 2 millimeter Gleason grade group 1 is going to make a difference as much as we do, but you've raised, you have cancer left behind. So we're going to have to learn how to counsel the patients appropriately, I think.
Finally then, your group have long had an interest in doing intraoperative assessment using various novel PSMA tracers and hybrid tracers to partly answer, intraoperative margin assessment, but perhaps even the residual cancer assessment, and some of that stuff is still maturing. But is there anything you can tell us about in Oxford, your ongoing work?
So intraoperative image-guided surgery is relying on being able to visualize cancer cells, and there are several approaches made, one in Amsterdam and Germany, and that's looking at radioactive molecules which are radioactive labeled, and then you can find whether there is radioactivity, but that's usually listening to a sound. Or there is the fluorescence techniques where you conjugate a PSMA. We're very lucky to have PSMA because it's so specific. And so you have a molecularly targeted or a molecule which targets PSMA. You conjugate that molecule with a fluorophore, and you use a laser technique like the Firefly to be able to visualize the fluorescence during surgery. The limitations are that you need to have equipment, the optical platform, which matches the wavelength of a fluorophore. And you need to avoid at all stages verification biases. So is what you see what you have. It's relatively easy with fluorescence imaging, because what fluoresces you can take out, and then therefore you can find out what's your false positive, what's your false negative, and you can draw conclusions. So the work we've done is very preliminary, it's very exciting. There are 2 other molecules, so there are 3 molecules now which have been published in pilot studies, and I think it will be very exciting to combine that with the confocal microscopy, for example, in the future.
Always good to see you, Freddie. It really is, and we look forward to welcoming you to Melbourne soon.
Thank you. I look forward to that. Thank you.
End of day 1 here, Renew, at the intraoperative margin assessment. It was a big day. We just finished the Delphi consensus. It's like 7 o'clock in the evening. Everyone's a bit mentally exhausted, I think. How are you?
Absolutely, yeah. No,
plus jet lag we have, yeah.
Yeah, add on the jet lag, can hardly get the words out. But yeah, no, we survived, and it was... Wow, it was a great meeting, wasn't it?
So one last chat for today. We've tracked down Joseph Tanzosh, who is works for Samantree, one of the companies that have this technology, confocal laser microscopy. You're VP of Clinical Affairs, I think, with Samantree, and you have the Histolog machine. So I thought we'd go right back to basics, Renew, and ask Joseph if he can tell us, what is this confocal laser microscopy that we've been hearing all about today?
The confocal laser microscopy is a great device. It's based on the principle of confocal microscopy, that's why it's called that way, which is allowing you to scan the surface of the tissue. What we made is we have miniaturized the whole confocal microscopy and made it super easy, and made it in a way that you can use it very quickly. It works like a sophisticated copy machine, so anything what you put on the imaging window is going to be scanned. And if you have a tissue, like a prostate, which has several surfaces, then you can scan one surface, turn it around, scan another surface, turn it around. You get an image within 1 minute, and it's a high-resolution image, which is comparable to 10x on final H&E or to frozen sections. It goes down to 2 microns per pixel.
Yeah, and it is very cool. The machine's cool, isn't it?
I mean, it sounds like a photocopier, but you know,
it's a sophisticated photocopier.
Yes,
indeed, it is amazing because you get down to the cellular level in 1 minute.
And for the dumb clinicians, when we see these images, it kind of looks like a H&E stain type thing. It doesn't look like tissue, it just like microscopy. Yeah.
Though it does a surface scan, so we have a native mode, which we call a black and white mode, and if you switch to the native mode and you zoom out, you can really nicely see the surface of the prostate, all of the encavements and other things. But then when you start zooming in, you go down to the cellular level.
So, Joseph, everyone knows this as Histolog. There must be other companies out there that make versions of confocal microscopy. What makes Histolog unique?
As I mentioned, we managed to miniaturize the whole technology and to make it super easy and super fast. We have the largest field of view today, so you can put specimens up there with 17 square centimeters. Some of the confocal microscopes which are on the market, they are used to very high precision imaging, but the imaging takes a long time, sometimes even half an hour for a very, very small specimen. And what we managed to do is you don't need any processing, any slicing, any cutting. The only thing what you need to do is to dip the specimen in the Histolog dip for 10 seconds, rinse it in saline solution, and you put it on the scanner.
We talked a lot in the meeting today, Declan, about what makes the quality of the scan. You know, is it, what kind of imaging do you need? We talked a lot about depth of imaging, exposure of the surface to the surface of the scanner. What are some prerequisites to get a good quality image that we can rely on?
Training.
Training, yeah, exactly.
I would say training.
Yeah.
As I said, the system is very easy to use, but there's some tips and tricks how to process the tissue and how to put it on the scanner so that you can get very nice quality image. It is about drying the specimen out properly, that it's not too moist, because you cannot have movements when there's a lot of fluid, blood or something on the surface. You need to understand that specimen needs to sit stable for a minute there.
Just a minute, though. Yeah.
It's just a minute, but it needs to sit stable there. So those tips and tricks on how to put it right on the scanner and how to dry it off and how to process it, they really make a difference.
And Renu, one of the questions that came up today was, okay, how do we train ourselves as surgeons, let alone the pathologists, to interpret these images? But what did you make of the discussions around AI? Because clearly it's imaging, and the whole rest of the world is overtaken by, well, AI can recognize images and stuff. But that was an interesting discussion.
It was an interesting, and I was going to ask you about, where do you think AI will go with this? But the feeling I got was that while AI can tell you if it's a good quality scan, it didn't seem worthwhile for AI to tell you what the pathology was, whether it was positive or not. Yeah. And the feeling in the room tended to be that, well, actually we can train surgeons to do this.
And the AI will catch up when it has a bigger data set, I think. Tell us a bit about that, because there are already plans to be developing the larger data sets so models can be developed, I think.
Absolutely. So I think in terms of the AI, what we need to understand that the scanner doesn't interpret the images at all today. We are just providing the images and somebody needs to read them. So is it the pathologist, is it the surgeon? Depending on the application profile, we do see that there are surgeons who are willing to learn how to interpret those images. It is not really rocket science, it is about pattern recognition. Therefore, also the question about AI is valid. But for that one, you need to have really a large data set. As we are collecting it now and we are doing the annotations, we are working on that. We are setting up the post-market observational registry, which will allow us to collect even more images from a routine use case that we can annotate them and feed the AI algorithm. So that will come, but that will take time. And in between, indeed, it's the pathologists within urology, but there's already surgeons who, if you get used to those images, you can start interpreting them.
I guess the other big question is, if you do have a positive margin, what do you do with it? And we talked a lot about, the different variations and variabilities that will influence your decision. And it's amazing, isn't it, how practice varies from place to place.
Absolutely. And I think, what the Histolog scanner allows you as a surgeon is to make an educated decision, what that decision is going to be and how does it impact the practice and what the data are going to be, which will support that decision. That's still in the future.
Look, I think all I can say about it is it's very exciting technology, and this machine does look like a really nice bit of kit. We have one at Epworth Healthcare in Richmond, and we're just about to start a prospective study contributing data back to this international registry. And here today you have surgeons from all over Europe and surgeons from the US dialing in, and all of whom are getting experience with this machine. So I think the era of intraoperative margin assessment using machines like the Histolog Confocal that's it. It's going to be growing, isn't it?
Absolutely. And tomorrow we're going to see some live surgery, that puts it into action. You're going to be there to support our surgeons.
So what are you doing tomorrow? You're going to go to the operating. We're going to be here in ORSI. All the AV guys have set up a very elaborate thing. There's going to be surgeries coming in from all over the world. But you're going to be here in Europe in an operating room with a Histolog.
We have 12 hours in the hospital just nearby, where most of the live cases are going to be done. And I'm just going to support the surgeons with the use of Histolog.
Look forward to seeing it.
Looking forward to it.
Thanks, Joseph.
Thanks, Joseph.
You're welcome. Thanks for having me.
So it's WRSE Day now, and the live surgeries have just kicked off. I'm here in the ORSI Academy, just outside the main auditorium, where we have a live audience and the live moderators, and all of that is being coordinated by a whole production suite upstairs. We might nip up and have a look, and we're watching these live surgeries. So at the moment we have 3 different partial nephrectomies on screen. Alberto Breda is doing one in Barcelona. Alex Mutri is doing one from here in an Alst just down the road, and Riccardo Schiavini also doing one. So 3 partial nephrectomies, mixture of transperitoneal and retroperitoneal approaches, and they're all going to have Histolog confocal microscopy performed on these specimens live so we can see them. Let's sneak into the auditorium and see what's happening.
The remember, usually there is one perforating artery going to the tuber.
What an intense couple of days that was.
Yeah, intraoperative margin assessment up to here. Yeah,
absolutely. And the marathon surgery is still going behind us. They're almost done. They're getting there. But yes, all about intraoperative margin assessment. And we saw the Histolog in action throughout the day.
Yeah, there it is. That's the
There it
machine.
is, yeah.
I'm sure you've been seeing bits of it through the podcast, and we have one of these at Epworth as well. But it's a nifty device. And watching the live surgery was quite impressive today, wasn't it? On the WRSE, because in multiple different procedures, they're popping out the prostate. It's going straight onto this in the operating room. We're watching the pathologist give a readout on it, and it was very impressive.
Absolutely. And it's been, we had the consensus meeting and then a whole day of live surgery and lots of questions yet to be answered.
Yeah, I want to pick your brain on it because
controversies.
I think everyone says, right, that's very impressive. And you can see, okay, right, look, real time, a few seconds later, you're seeing that specimen on the thing. But it's all about the questions, the impact, Renu. That's what the consensus was about. And then Freddie Hamdi talked about it earlier. It's very impressive, but what to do with it or what questions to ask? How do we make sure we're going to be able to help our patients?
Yeah, I mean, I think those are the big unanswered questions. And, the theme that keeps coming up is with this technology, it's great, you know what you've taken out, but we still don't know what we've left behind. And until we can bridge that gap, we've still got work ahead of us.
Yeah.
But, what a great place to be here at the ORSI Academy. So we want to say a big thank you to Alex Mottry, to Ruben de Groot, and the whole team here that hosted us and enabled us to really get behind the scenes.
Yeah, it is a very impressive place, and it was really nice to come back here after all those years when I'd been here before. It's not just the physical nature of the place. There's a really good group of people, great leadership, Mottry and de Groot and everybody. And if you get a chance to come here to ORSI Academy for a course, it's a great place to be.
There's a true passion for training, and we can see it right throughout. And I think if we come back in a few years' time, it's going to be different again because they keep expanding. So it's very impressive to see.
That's all we have time for on this episode of GUcast from here at the ORSI Academy, the second of our podcasts from ORSI Academy in recent times. It's been great and we hope you enjoyed it.